Good evening, and thanks a lot for joining me tonight for a little discussion on depression. My name is Patrick Finley, and I'm a clinical professor in the School of Pharmacy here at UCSF, specifically in the area of psychopharmacology and behavioral health. And I know on your handout there's a kind of an extensive bio sketch there, but in terms of a really brief background, I am a clinical professor, and what that entails is I do quite a bit of teaching here and research, but also it means I have a clinical practice. And that clinical practice just so happens to be a depression clinic at the UCSF Women's Health Center, where I deal with nothing but depressed patients, which I find very rewarding. So I think I'll have quite a bit to share with you, not only from an academic perspective, but also an anecdotal one. So you'll also notice the title's a little bit different than what's in your syllabus. And I apologize, but the reason this was changed a long time ago and never was changed in the syllabus is because I want to be a little more specific here and emphasize 2 points. One is that we're not doing a very good job dealing with depression here in this country. Our mental health system is broken effectively. And secondly, I really want to emphasize ways that we can improve outcomes. So with that in mind, I thought I'd begin just by sharing with you a poem. This poem was written by Jane Kenyon. I don't know if you've heard of Jane Kenyon, but she was married to Donald Hall, who was the poet laureate, I believe during the Clinton administration. And she was a wonderful poet in her own right, and actually died at a relatively young age of cancer. But during her short life, she had a very severe form of depression and wound up being stabilized on a real exotic combination of medications. In case you can't read this in the back, we try a new drug, a new combination of drugs, and suddenly I fall into my life again, like a vole picked up by a storm, then drop 3 valleys and 2 mountains away from home. I can find my way back, I know. I will recognize the store where I used to buy milk and gas. I remember the house and barn, the rake, the blue cups and plates, the Russian novels I loved so much, and the black silk nightgown that he once thrust into the toe of my Christmas stocking. And for those of you who are more visually inclined, this is a painting called On the Threshold of Eternity that was painted by Vincent van Gogh, who was no stranger to depression. This was actually painted during one of his blue periods. He had really a very notorious blue period. And you can see he very accurately depicts what looks like an older man under the throes of depression here. Now, when we think about what depressed people look like, ordinarily we think of someone who's tearful and sad and melancholic. But actually the presentation of depression can be quite diverse. For example, a lot of people are surprised to learn that depression can present with extreme irritability and anxiety. In fact, that's not an uncommon presentation in elderly patients, and it's often their spouse or a caregiver who notices that they're more irritable, and ultimately that diagnosis is entertained. But also a lot of people present with what they call emotional numbing or flatness. They'll withdraw socially. They may notice that their brains aren't working as efficiently as they were previously. So it really can be all over the map. So I wanted to share with you technically what the diagnostic criteria is for what we call major depressive disorder. And I should explain that for the most part tonight when I'm talking about depression, I'm talking about major depressive disorder. As near as I can tell, this is what the media refers to as clinical depression. So to wit here, you need 5 out of these 9 symptoms for at least 2 weeks. And you need at least one of these first 2. Either a depressed mood or something called anhedonia. So you'll notice right off the bat here, interestingly enough, that you don't necessarily have to be sad or have a depressed mood to satisfy the criteria for major depression. Either depressed mood or anhedonia, and a total of 5 of these symptoms. These next 3 here are more or less physical symptoms. In psychiatric circles, we call these neurovegetative symptoms. Change in appetite, usually it's a decrease, but it can go either way. Same with change in the quality of sleep. It's usually a decrease, but it can go either way. And then hopelessness, worthlessness, and a lot of guilt and ruminations. This one's kind of subtle, diminished ability to think or concentrate. In fact, a lot of the people I interview are surprised to learn that this is a symptom of depression. But when you're interviewing them and asking them, for instance, about their ability to finish reading an article in the newspaper or paying attention to their favorite TV show, they will notice that they're no longer able to do that, but they didn't associate that with depression. What also goes along with this is an inability to make decisions. Next is psychomotor agitation or retardation. And what's meant here by psychomotor agitation, these are people who more or less look irritable and depressed. They may be pacing or wincing or grimacing, wringing their hands. At the other end of the spectrum is psychomotor retardation, which is kind of lump on a log syndrome. You know, they don't project a whole lot of energy or happiness. They're very monotone, not much facial expression. So these are two extremes here. And then lastly, of course, recurrent thoughts of death or suicide. And it's estimated that about 2/3 of people with major depression will think about death or suicide. So it's 5 out of these symptoms for at least 2 weeks. Now, in terms of how commonly depression strikes our culture, you've probably heard a lot of figures bandied about. And so what I wanted to fall back on here is what I consider to be sort of the landmark study in regards to the epidemiology of depression. What they did is they actually interviewed over 9,000 households, face-to-face surveys, and they wound up estimating that about 1 in 6 of us will suffer from major depression in our lifetime, about 16% of us. And if you want to talk about the annual prevalence, it's about 6.6%. If you want to talk about point prevalence, meaning right now how many of us are depressed, it's around 3 to 4%. So that's major depression. That doesn't factor in something called dysthymia, which is a term you may have come across, which is a milder form of depression, but it's actually much more long-lasting. The symptoms have to be present for at least 2 years. And if you factor in dysthymia, it may roughly double these figures. Now, what I thought was really interesting in this study was right here. It's kind of buried in the slide, but over half of the people who they discovered had major depression were concurrently suffering from an anxiety disorder. So over half of them also had an anxiety disorder, which, to get way ahead of myself here, this is one of the reasons, I think, why the SSRI antidepressants are so helpful. That's medications like Zoloft and Celexa and Lexapro and the like, because they're not only very effective for depression, they're also very effective for anxiety disorders. And then these last 3 bullet points are kind of sobering. Only about half of the people who actually had major depression received any treatment. Of those who had treatment, about 42% of them had adequate treatment. So if you do the math here, 21.7% of these people were adequately treated. And these kinds of numbers really haven't changed much in spite of some of the efforts that's been taken on by the government in recent years. Now, a couple of other things I didn't mention about epidemiology, and they're not reflected in any slide, have to do with gender and chronicity. You're probably aware of the fact that women are more likely to suffer major depression than men are. What I think a lot of people don't realize, though, is that's only true during the reproductive years. So if you look at boys and girls prior to menarche, the incidence of depression is more or less the same. If you look at men and women in their geriatric years, it's more or less the same. It's only during those reproductive years where the incidence is about twice as high in women as it is in men. And perimenopausally, it's actually 3 to 4 times as high. And also, depression really should be looked at as a chronic illness. You've probably heard that before, but it really is a chronic illness. Just to throw some numbers out there, after 1 episode of depression, a little over 50% of people will suffer a second episode. After a second episode, there's about a 70% chance of a third, and after a third, there's a 90% chance of a fourth. Not to scare you, but I think what that really gets at is the importance of treating depression adequately and as soon as possible. So not surprisingly, the burden of this illness is huge. These are World Health Organization figures from back in 2001, and you can see that depression actually is number 1. The burden of the illness is greater than alcohol abuse, arthritis, diabetes, heart disease. So it wouldn't surprise you that the impact of this illness is also tremendous. If you want to look at it from the patient's perspective, it can be ruinous. You know, there's a significant decline in self-esteem a lot of the time. People are less productive. Relationships may suffer. And then these other things can be affected as well. What we often don't take into consideration is what happens in the home when someone in that household is depressed. There's a new term that you may have heard of called parental depression, which is getting a lot of airplay these days in terms of some of the research that's being done, specifically in regards to the impact of depression on that household. So you could be talking about depression postpartum, you could be talking about depression during pregnancy, but you could also just be talking about one of the parents being depressed and what that does for the child in the long run. There's an increased risk of substance abuse and domestic abuse. And Without a doubt, we know that the offspring of people who are depressed are much more likely to suffer psychiatric illnesses themselves, and that's independent of genetics. So it is an environmental influence here. The impact on work is incredible. We're finally getting some decent research in this area, and it's believed now that depression is the #1 cause of absenteeism and presenteeism. If you haven't heard the term presenteeism before, basically what that implies is that these people are showing up for work, but they're pretty much dysfunctional. And in fact, if you want to talk about cost figures, the cost of presenteeism is much greater than that of absenteeism. About 10% of employees may be depressed during any 2-week period. So you can see lost productivity, 4 hours per week per depressed employee. And in fact, if you want to talk about how to improve the treatment of depression, who should be paying for it, I think you can make a pretty solid, cogent argument that it should be the employer to some extent who's facilitating care here, because they're really the one that benefits, at least from an economic standpoint. And then lastly, overall health. This to me is really fascinating. We've known for some time that people who have chronic illnesses are more likely to develop depression. We now know the converse is true, meaning that, for instance, people who are depressed are much more likely to develop diabetes. They also appear to be much more likely to develop Alzheimer's disease. There's studies that have actually followed cohorts of elderly patients, and what they found is that new onset depression in a geriatric patient, within 3 years, about 57% of these folks now have the diagnosis of Alzheimer's disease. Again, depression precedes the Alzheimer's disease in most of these cases, which has led people to theorize that maybe new onset depression is actually a prodrome towards the development of Alzheimer's disease. So how do we explain that? Well, I'll throw some theories at you in a second. So we know that depression is commonly associated with a lot of illnesses. This is a really important take-home point here too, though, and that is that depressed people, not only are they not great at taking medications for depression, they're not particularly good at taking any of their medications. And studies have shown that their medication adherence rates plummet once they become depressed. So if you want to talk about the cumulative burden of medical illness, by stopping these medications, they're really not doing themselves a favor. Question? Right. The question is, when I'm talking about treatment, am I talking about medications or all treatments? And I'm actually talking about all treatments unless I'm more specific. So in terms of the incidence of depression with these various other illnesses, these are point prevalences, meaning that if you look at people with heart disease here, coronary artery disease, if you look at them right now, about 30% of them will have depression. And you look across the board here at how strong this association is between depression and these other illnesses. And if you want to know about the general population, well, again, about 3 to 4% of us right now have major depression. So you can see it's pretty impressive. If you're a little more practical, this was a study that was published quite a while back. And basically what they did is they looked at why people came into primary care clinics, and then on their way out the door, they screened them to see how many of them actually had depression or anxiety disorders. So for instance, about 59% of people who came into the primary care clinics up there in Washington had some kind of joint pain. And then once they were subsequently screened, about 24% turned out to have an anxiety disorder as well, and 34% had depression. And as you look down the list here, it's pretty impressive. In fact, if you look at chest pain, almost half of the people who came in with chest pain had major depression or significant depression. This is just a little depiction of the heart working overtime, perhaps in someone who has maybe heart disease as well as depression, and there's a very strong association there. Now, how do we explain that? I don't want to spend too much time on this because the bottom line is we simply don't know. But in terms of what causes depression, it still looks like it's a combination of genetics and environmental factors, nature and nurture. However, I think there's a growing emphasis on early adverse life experiences, neglect, abuse, what have you, as predisposing people to development of depression later on. So it's a combination of nature and nurture, and then usually there's some kind of current life stressor, which precipitates the depression. And if you're wondering how that's mediated, we talk about the fact that it looks like depression is associated with a decrease in serotonin functioning and norepinephrine functioning. Most of us think that's kind of happening downstream. and that the true insult is either in the HPA axis or it's in the increase in something called inflammatory cytokines. Personally, I think there's very compelling evidence that it's the inflammatory cytokines, which are kind of the common denominator here, causing these medical illnesses as well as depression. And in fact, I think this was a couple of years back in Time magazine, they devoted an entire issue to the association between inflammation and various illnesses. And in fact, I mentioned the fact that depression is a chronic illness. We should really think of it as a chronic inflammatory condition. What is the goal of treatment? What are we shooting for? And there's an interesting controversy here. Now, historically, what we've shot for was what we called a quote-unquote therapeutic response. And that was defined rather arbitrarily as at least a 50% decline in some kind of depression rating scale. That's the way it was defined in the clinical trials and so forth. We now know, though, that we were probably not as aggressive as we should have been. And in this day and age, what we're really shooting for is something called remission, which is the virtual absence of symptoms. What I have here is a HAM-D of less than 7. The HAM-D is one of the most common depression rating scales, and basically they've created this cutoff of 7. And people with less than 7 on the HAM-D, for all intents and purposes, are in remission. So again, in this day and age, what we should be shooting for is remission. Now, in regards to the title tonight, why better is not good enough, I think this slide basically answers why. What you're looking at here are the fates of people who achieved remission versus those who had simply a therapeutic response. So it's a survival curve, and on this red line here, what you're looking at is the patients who relapsed over the course of the next 12 months. So you can see out to 12 months, around 20% of the patients who had remission initially relapsed. Again, only 20% relapsed. Whereas if you look at those who were therapeutic responders, almost 80% of them had relapsed after 12 months. The way they usually quantify depressive symptoms is by using a depression rating scale. And there's a lot of different rating scales. The HAM-D has been used traditionally, but it has some problems. And what it is basically you're checking off boxes in terms of which depressive symptoms you have and how severe those are. So that's how they're quantifying the depression here. Now, another way to look at it is, well, among those patients who are therapeutic responders, how much were they still suffering? Because if you think about it, if someone has severe enough depression, even if you reduce their symptoms by about 50%, the severity of their symptoms, they can still be in trouble. They can still have a lot of these depressive symptoms. So what you're looking at here are the what we call residual symptoms of people who actually satisfy the criteria of therapeutic responders. This was from the clinical trials that were conducted with Prozac way back when. And you can see even among these responders, who we would have thought of as therapeutic successes in the past, over 40% of them still had sleep problems. Almost 30% still had anhedonia, so they couldn't enjoy themselves. A lot of fatigue here, and problems with guilt and concentration. So you can see that there's a lot of room for improvement. So what are our treatment options? Well, there's actually a lot of them. The focus tonight is going to be a little bit more on pharmacotherapy for obvious reasons. I'm a professor in the School of Pharmacy, but also because I think in this day and age, in this managed care environment, we really are emphasizing medication at the expense of psychotherapy. I don't agree with that, but that's the way we're managing medication in the United States today, managing depression in the United States today. So if you look at the different treatment modalities here, it's psychotherapy, pharmacotherapy, and it's other. And I can tell you that I firmly believe in a three-pronged approach to depression: psychotherapy, pharmacotherapy, and lifestyle changes. And that's not possible for everyone. They may have something against medication, they may think psychotherapy is inconvenient, or maybe their insurance doesn't reimburse psychotherapy to the extent that it should. But ideally, I believe in this three-pronged approach. And it's, in terms of lifestyle changes, I'm a firm believer in exercise. If you look at it from an evidence-based medicine standpoint, it's been kind of hard to show that exercise in and of itself can cure depression. However, what it can do is improve self-esteem, regulate appetite, regulate sleep patterns, can even increase serotonin. There's also something called mindfulness that I listed up here. I don't know if you've heard this term before, but the full term is actually mindfulness-based meditation. And most of the major medical centers around the country now are offering this. It's wonderfully effective for not only depression, but a lot of other conditions, cancer and what have you. And we offer it 2 places here at UCSF. We offer it at Langley Porter, and we also offer it through the Osher Center. So if you have any interest in mindfulness-based meditation, I would suggest you simply Google Osher and mindfulness, and their schedule will come up. I can tell you a lot of patients I've sent to mindfulness have got a lot out of it. It's not a passive approach at all. And I should also mention that some of these other options I have listed here I'll be talking about a little while later. Now, in regards to kind of the age-old argument of pharmacotherapy versus psychotherapy for depression, if you look at it again from an evidence-based medicine standpoint, the two are equally effective for mild to moderate depression, more or less. If you want to talk about severe depression, it's very clear that the combination is more effective than either one alone. My mantra, if you will, among the patients I see is that I tell them that medication is really effective for controlling the acute symptoms of depression. And what medication does is it kind of gives you a chance to think about ways you could change your life or your thinking so you don't wind up in this situation again. In other words, medication kind of lets you see the forest from the trees, but then it's up to you, I think, to make these insights, and that's really where psychotherapy comes in handy. One of the nice things about medication is that it works relatively rapidly. So again, it acutely controls the symptoms. Psychotherapy takes a little while longer. And in fact, if you look at the literature, that's the only thing you can really definitively state is that medication has a more rapid onset of effect. Although I personally think that the benefits of psychotherapy are much longer lasting. That is, if you stop both of them today, the benefits of psychotherapy will last longer because people develop these coping skills and what have you. So before we talk about the differences among the antidepressants, I would just want to make it clear that all the antidepressants are exactly the same in 2 different respects. They all have this delayed onset of effect, and they all have more or less the same response rate. So in terms of delayed onset, generally it takes 1 to 2 weeks before people start to feel better. Now that may be news to some of you because for whatever reason, a lot of providers, a lot of pharmacists, what have you, tell patients that it takes a month before you start to feel better, which is not true. Usually if someone's going to get better, within a week or 2, we'll see some signs of improvement. And it's really a month, maybe 6 weeks at the most, to maximal benefit. And I won't go into the reasons why there's that misconception because it's a little bit complicated. It has to do with study design in the clinical trials and so forth. So 1 to 2 weeks before people start to improve, 4 to 6 weeks to maximum improvement. I would make the exception, though, that in the elderly it may be a little slower than that. So it may be 3, even 4 weeks before you start seeing some significant improvement, and 6 to 8 weeks would be a therapeutic trial. Now, overall efficacy, all of us health professionals at some point were taught that about 2/3 of the patients given a trial of any antidepressant will have a therapeutic response. So the first antidepressant we try, about 2/3 of the time will be successful, 60 to 70% response rate. And if we want to talk about remission rates, they're about 30 to 40%. So that's what we were all taught. The problem is you have to ask yourself where that number came from, this 60 to 70% response rate. And where that actually came from are these phase 3 clinical trials that are conducted before a drug's FDA approved and released. In those studies, you're looking at a very contrived environment. You're looking at people with severe depression, for the most part, who actually have very little medical comorbidity, in other words, no other medical illnesses. And they're also getting a lot of attention from the researchers. And they have incentives for remaining in the study. So these response rates are almost certainly overstated. What do we see in real life? And there was a series of studies that continue to be published as we speak. These were the so-called STAR-D investigations. And basically, that's what they were trying to figure out. In the real world, how effective are these antidepressants? If the first one we try doesn't work, where do we turn next? So this was the first level of the study. And what they did is they enrolled a little less than 3,000 patients from not only psychiatric settings, but also primary care, which is where most depression is actually treated. And the way what's kind of interesting is the way they enrolled these patients didn't involve any recruitment whatsoever. It was entirely up to the provider whether or not they thought the patient was sufficiently depressed. So you wound up with real-world patients. Rather than severe depression, they had mild to moderate. They're enrolled in this study, and then they're given this very rigorous trial of something called citalopram. The brand name was Celexa. You may have heard of it. So they used citalopram as the first step of treatment, and what they did is they based the dosage titration on their depression rating scale. So if they had a certain number on their depression rating scale, that told them to increase the dose or just sit tight and maintain the same dose. Ultimately, what they wound up with, though, was pretty aggressive dosing. I think a little more aggressive than the real world, over 40 milligrams a day. But what's really disturbing is right here. Only 47% of these patients in this quote-unquote real-world study had a therapeutic response. So only half of these patients had, a little less than half actually had a therapeutic response. So that makes us wonder about these clinical trials, and I've already kind of touched on this slide more or less about some of the problems with clinical trials. I'm talking about these randomized controlled trials that people are enrolled in. The point I want to make here, though, is this also to some extent explains why in a lot of studies placebo doesn't separate from antidepressants. They're comparable. There's no statistically significant difference. To explain that further, you have to think about this environment. It's very contrived, a lot of contact with the patients, and that contact itself is a psychosocial intervention. You know, when people talk about placebo not separating from antidepressants, that there's no difference, what they're basing that on is these studies, and this is not the same as someone walking into a pharmacy and purchasing placebo. There is this psychosocial intervention. So, very important take-home message here is that the majority of people started on an antidepressant will ultimately need some change in their regimen. That is, changing to a different medication, changing the dose, what have you. And I think this is really where our system falls apart, because the follow-up tends to be not very thorough by most providers. Also, I think a lot of providers have their favorite antidepressant of choice, but once you start looking at second and third line agents, all bets are off. So these are the different classes of antidepressants. I'll try to mention generic names in addition to brand names, like venlafaxine is also known as Effexor. Duloxetine is also known as Cymbalta. Bupropion is Wellbutrin. Trazodone is generic. Mirtazapine was known as Remeron when it was a brand name medication. And I'll get to the SSRIs in a second. So I have the different classes here kind of prioritized. You can see the SSRIs are at the top of the list. To be honest, I'd say in primary care, 80 to 90% of the time we start with SSRIs. Again, they're very good for depression and anxiety disorders. Sometimes, though, we may start bupropion as a first-line agent, and I'll get to the instances in a few minutes here. And sometimes we may start venlafaxine or duloxetine, and rarely something like mirtazapine, again, as a first-line agent. So I want to talk a little bit more specifically about the SSRIs here. And these are the SSRIs that are currently available in the US. You can see most of them are available generic, which is great. So the cost of these has decreased substantially. You can also see that Prozac's 20 years old. Hard to imagine. And for the record, all of these are FDA approved for the management of depression except one. Does anyone know which one of these is not FDA approved for depression? It's kind of trivia, but Luvox, fluvoxamine, is technically only FDA approved for something called obsessive compulsive disorder. It is a very effective antidepressant, but they just never went after that indication. So in terms of how these medications work, a little pharmacology here. Basically, the way impulses are propagated in the central nervous system is an impulse travels down and affects the release of these neurotransmitters into the synapse. And once these neurotransmitters are released into the synapse, they basically have three different fates. They can bind postsynaptically, and then this impulse continues to be propagated. They can be metabolized in the synapse and lose their effectiveness, or they can be taken back up into the presynaptic terminal and stored in these vesicles here. The way the SSRIs work is that they actually block that reuptake. So they're effectively increasing the concentration of serotonin in the synapse. That's one of the ways that they enhance serotonin. And you're probably wondering, why do we have such a complex system in our bodies for propagating nerves? You know, why doesn't the impulse just continue? And the answer is that, you know, by having this action where the different neurotransmitters are released in the synapse, we can modify the impulses that take place throughout the brain. So it's kind of an ingenious system when you think about it. Now, most of the antidepressants Well, as I mentioned before, there aren't really substantial differences in terms of their overall effectiveness. So I want to talk a little bit more about their side effects, which is certainly more of a public concern, I think. If we look at the SSRIs first, we've had so much experience with them, I think we're pretty comfortable with the major side effects. And they basically consist of gastrointestinal side effects, central nervous system side effects, and sexual side effects. The GI side effects, gastrointestinal, are usually relatively mild and short-lived. So a lot of people who start them will have some mild nausea, which is why we always recommend taking them with food. But ordinarily, it will go away with time. The CNS effects are a little more complicated. We tend to think of the SSRIs as being relatively activating. And what I mean by that is, in a good sense, they increase energy. In a bad sense, they may cause some insomnia or even agitation. So along those lines, there is a hierarchy here where I think most experts would agree that Prozac is the most activating, which again can be a good thing or a bad thing. Next would be sertraline or Zoloft, then Lexapro or Celexa, also known as S-citalopram, and citalopram or Celexa. Most people would say Paxil is a little more on the sedating side versus insomnia, and I would agree. It's a little more sedating than these other ones. And then the only one that's genuinely sedating is Luvox, which we don't use very much of. One other interesting effect we see with the SSRIs is that they cause vivid dreams. And in fact, if you look at the effects of SSRIs in someone who doesn't have depression, specifically on their sleep architecture, the SSRIs don't have great effects on sleep architecture, to be honest with you. They actually promote REM sleep, which is why you get these vivid dreams. Now, having said that, if the SSRIs are effective at treating the depression, usually the quality of sleep improves. And one important distinction I want to make here before I move on is between onset insomnia and mid-nocturnal insomnia. Onset insomnia is what the SSRIs can cause. That means difficulty falling asleep initially. And in fact, when I'm seeing someone that's complaining of onset insomnia, I usually think maybe they have really poor sleep hygiene, or maybe they're suffering from an anxiety disorder. Whereas if someone has depression, the classic form of sleep disorder with depression is mid-nocturnal insomnia. That means waking up around 3 or 4 in the morning and not being able to get back to sleep. In fact, there's a term for it in Chinese medicine, which I can never remember, which implies that mid-nocturnal insomnia really is highly characteristic of depression itself. Question? Sleep hygiene means things you can do to improve sleep. And it's something I can recite in my sleep because so many of the patients I have in the depression clinic have sleep problems. It's things like avoiding big meals late at night, minimizing the use of alcohol. A lot of people don't realize that alcohol, yes, it can make people fall asleep more easily, but it actually prevents people from dropping into the deep sleep that they really need. Stage 3 and 4 sleep, which is more restorative. So it's avoiding big meals, avoiding alcohol, or at least minimizing use, not watching TV in bed or reading books in bed, making sure that you can't see clocks from your bed. I always wonder why people want to look at clocks and when they can't fall asleep and know how much sleep they're missing. It's all about the quality. It's not the quantity. Making sure the room's relatively cool and quiet, and also going to sleep at the same time every night. Which can be really difficult for the first few nights, but once you actually get in a sleep pattern like that, it's enormously beneficial. Question? Sleep architecture is the different phases of sleep we go through at night. There's like stage 1, stage 2, stage 3, stage 4 in REM sleep. Stage 3 and stage 4, that really is the goal. That's where our immune systems are restored and so forth. Stage 1 and 2 is relatively light, and we don't really understand why we have REM sleep, but it's not necessarily a good thing. It's fascinating. Now, the number one reason why people stop their antidepressants, or SSRIs more specifically, due to side effects is sexual dysfunction. Roughly 30 to 50% of people started on an antidepressant will have sexual dysfunction of varying degrees. And there is a hierarchy here. You can see paroxetine and fluoxetine are probably the worst, but it certainly happens with sertraline, citalopram, and S-citalopram. And as you can see here, there's a huge range in terms of the incidence depending on the quality of the study. Like in the antidepressant trials, and what's in the package insert is a gross underestimation of sexual dysfunction. The reason being that they don't ask people about sexual dysfunction in the clinical trials. And it's not the sort of thing that people are ordinarily going to volunteer. In fact, one of the newer antidepressants, when it was approved recently, I asked one of the people with the company, why don't you monitor the amount of sexual dysfunction that you're seeing in these clinical trials so we have an accurate estimate? And he said, why do we want to do that? That would be suicide. We would look so much worse than any other antidepressant that's out on the market. Suicide's probably a poor choice of words. Sorry about that. So in terms of sexual dysfunction, what's vitally important here is to distinguish the type of sexual dysfunction. The main reason being that most people who are depressed, and studies show we're talking about 90% of people who are depressed will have a decrease in their libido. So depression itself causes a decrease in libido. And if I'm seeing someone like 6 to 8 weeks out and they're still telling me that they have a decreased libido, my first thought is that they're still depressed or that they're in a bad relationship or something. Whereas orgasm problems are much more common with the antidepressant, and specifically it's a delay in achieving orgasm. In terms of management, a lot of the time what happens is people have a good response to the medication, but they're telling us that they're having this delay in their orgasm. A lot of the times they may not mention it. They'll tell you it's worth putting up with, because their life has improved so substantially. But then a lot of the time, they'll just say, why am I putting up with this? And they'll just stop the medication, and you'll never hear from them again. So we have to get it out in the open. And if, in fact, they're doing well, but they're having this problem, the first step is to lower their dose. It is dose-dependent. If that doesn't work, we'll often add other medications to treat the sexual dysfunction. The number one option here being Wellbutrin or Bupropion. Recall, this is a different antidepressant. But it's actually very effective for treating this sexual dysfunction. About 50% of patients will respond to the addition of Wellbutrin or Bupropion. Viagra is wonderfully effective too. Studies have shown convincingly that men who have sexual dysfunction due to antidepressants respond really well to Viagra. And there's some anecdotal information that may help in women too, but I haven't really seen a study that's opened my eyes yet. And I just thought I'd share with you this kind of amusing study which gets at the hierarchy among the SSRIs. This was a study that was done in men who had premature ejaculation. They had to have what was called an IELT, intravaginal ejaculatory latency time, of less than 60 seconds. And the average actually was 15 seconds. And if you're wondering how they measured this, their partner had a stopwatch, literally. And I don't know why, but I find it amusing that the study was conducted in Amsterdam. But anyway, so they took these men who had a problem, and they randomized them to one of these therapeutic doses of SSRIs. You can see Prozac or Luvox or Paxil or Zoloft. And this is how much it increased their IELT, in Prozac's case, by 117 seconds. That's a dramatic effect. And it's actually a therapeutic effect in these guys, but in most people, it's a problem. But you can see, again, that Prozac and Paxil are a bit worse than Zoloft or sertraline. And if you're wondering where Celexa and Lexapro fit in, they're pretty similar to sertraline in terms of their effects on sexual function. Other side effects, sweating is pretty common, but it's relatively rare that people stop due to this excessive sweating, and there are some antidotes for it. Teeth grinding can also occur with the SSRIs. Weight gain can occur with any of them. It's very rare with most of them, the exception being paroxetine or Paxil. Paxil is notorious for weight gain. SIADH is kind of an obscure side effect, obscure in terms of the title, but it's actually quite common. That's delusional hyponatremia. These are people whose serum sodium drops. Worst case scenario is that they could develop seizures. Fortunately, seizures are pretty rare. SSRI withdrawal, I would imagine many of you have heard that if you stop these medications abruptly, you can have withdrawal symptoms. And classically, what the SSRI withdrawal symptoms are things like dizziness, shooting pains in the extremities, or what patients often describe as brain zaps. Don't ask me what that term means, but I've heard that so many times from my patients that if they go on vacation and stop their medication, they get these brain zaps. It's not life-threatening, but it can be really uncomfortable. And by the way, the only SSRI which does not cause withdrawal is Prozac. The reason being that it's so long-lasting that it's kind of self-tapering. GI bleeds, there's some circumstantial evidence that SSRIs may predispose people to gastrointestinal bleeds. We don't really know what the clinical ramification of this is yet. I think the clinical significance is that if someone's on a non-steroidal anti-inflammatory drug like Motrin or Naproxen and they're taking large doses around the clock, I would really hesitate to prescribe an SSRI because the combination looks like it's particularly troublesome. Osteoporosis, this was in the news recently. I thought someone might ask me about it, so I threw it up here. But there's some evidence that the SSRIs may predispose to osteoporosis, but the truth of the matter is that we've known for a long time that depression itself predisposes to osteoporosis. And this issue with suicide I also thought would come up tonight, so I thought I'd cut to the chase here and talk a little bit about that. I'm sure you're aware that about 4 years ago, this was a big issue in the news that in some of the studies, the SSRIs were associated with an increase in suicidal ideation, that is thinking about committing suicide. It's important to note that in none of the clinical trials was there a suicide, but there was potentially an increase in suicidal ideation. And so they went back and they looked at the studies, and what they actually learned was that a number of the studies, the data was buried. The drug companies actually never released the data. So once they finally got them to release the data, and that's actually required now, they did find that there was a trend towards an increased risk in children and adolescents. That is, there could be an increase in their suicidality shortly after they started the antidepressant, whereas in geriatrics there was a decreased risk. I would emphasize that it was relatively rare, this increase in suicidal ideation in pediatric patients. We don't really know what to attribute it to, but it is rare. You know, it could be that they simply weren't responding to the antidepressant. You know, if you think about it, usually at the point when we start an antidepressant, people are doing their worst. You know, that's why we started the antidepressant. And if the antidepressant has no effect in them, they could just continue on that same trajectory. It could be that there's a delayed response, that their somatic symptoms got better and they now have the energy to hurt themselves and they didn't have that before. But to be honest with you, there's really no scientific support for that theory, but everyone talks about it. What I think holds a little more weight is right here, this extreme agitation or akathisia. There are some people who start these medications who become, for whatever reason, extremely agitated. They're very rare. There is some evidence now that it's linked to a specific gene. But I think this may have something to do with it. That and the fact that if you look at the doses, the cases of suicide that I've seen in children, if you look at the doses that they were taking, they were adult doses, and they were being started on adult doses. So the bottom line in my mind, though, is that untreated depression is much more likely to induce suicide than any antidepressant. I don't know if this caught your eye, but within the last year, there have been several studies that have looked at prescribing trends with antidepressants. And since the FDA came out with this warning, there was about a 25% decline in the prescription of SSRIs. And at the same time, they've learned that there was an increase in suicides. So it's kind of made the FDA think twice about black box warnings. About SSRIs causing GI bleeds. Well, the evidence is actually severe GI bleeds, and it's based on insurance data claims. So they looked at millions of patients. They did find that there was an increase in hospital admissions due to severe GI bleeds, gastrointestinal bleeds. But you have to wonder, is it the antidepressant or is it the depression? You know, if you think about this strong association between depression and other medical illnesses, who's to say that there's not also a predisposition there to GI bleeds? Oh, I'm sorry, yeah. So in terms of how I would interpret this data right now, I do think that if someone's taking a non-steroidal anti-inflammatory drug in high doses around the clock, you know, something like Motrin or Naproxen or Indocin for the treatment of arthritis, say, I would hesitate to start an SSRI. Because I do think there may be a risk here. We do know that the SSRIs decrease what we call platelet aggregation. So there may be a reason here why they're causing this. To put a positive spin on it, we also know that this decrease in platelet aggregation is a really good thing in someone with heart disease. And there's some compelling evidence that the SSRIs actually decrease the risk of MI. Very compelling evidence. They're never going to have that FDA indication because they're just never going to do those studies. They're too expensive. But it is kind of interesting, and they are an excellent choice in someone who, even people with really unstable heart disease have done well on SSRIs. Now, I do need to talk about drug interactions. I know this can be really boring, so I'm going to try to summarize it, but in general, antidepressants can inhibit the metabolism of other drugs. What they do is they have an effect on something called the cytochrome P450 system of liver enzymes, although it's also throughout the body. It's not just limited to the liver. But what they do is they inhibit certain enzymes there. And the families, the specific enzymes we've learned the most about are cytochrome P450, 2D6, and 3A4. And the significance of this is that if someone's taking one of these drugs here, beta blockers, narcotics, or tricyclics, these are metabolized via 2D6. So if, for instance, someone's on a beta blocker like Inderol, propranolol, for controlling their blood pressure, and you start something like fluoxetine, which is Prozac, what it's going to do is inhibit the metabolism of that Inderol, increase the Inderol concentrations in their bloodstream, and the manifestation of that will be things like slowing their heart rate, maybe bottoming out their blood pressure, could even trigger falls. So these are the medications which inhibit 2D6. Fluoxetine, which is Prozac, paroxetine or Paxil, duloxetine or Cymbalta, and bupropion or Wellbutrin. 3A4 is actually much more clinically relevant. And the reason I say that is over 50% of drugs which are dispensed are actually metabolized through the 3A4 isoenzyme. So what you're looking at here are things like calcium channel blockers, estrogens, steroids like prednisone, statins, Viagra, and some other medications. The good news here is that there's really only one medication to worry about, and that is Prozac. Norfluoxetine is its active metabolite, and it's a moderate inhibitor of 3A4. So if you don't remember anything else, the least likely to interact with other medications are sertraline, which is Zoloft, citalopram, which is Celexa, S-citalopram, which is Lexapro, and venlafaxine, which is Effexor. Now, there's a different type of interaction also associated with the antidepressants, and it doesn't occur pharmacokinetically, it occurs pharmacodynamically. In other words, it has nothing to do with liver enzymes. It has to do with the fact that these medications are all enhancing serotonin. So if you combine two medications which enhance serotonin, at least in theory, you may run the risk of something called serotonin syndrome. This is very rare, but very, very serious. So there are certain medications it's commonly associated with where it's a good idea, I think, to avoid any of these combinations. So anything listed here under most commonly associated or commonly associated, I don't think it's a good idea to mix and match these medications. So the MAO inhibitors were the most notorious, but we don't really use them too much anymore. Those were things like Nardil and Parnate. There's a new one that's actually a patch. It's called MSAM, which is selegiline, which is slowly catching on. It's extremely expensive. So any of these medications, it's not a good idea to combine them. If you do combine them, you run the risk of these symptoms like mental status changes, myoclonus or rigidity. There's a lot of autonomic instability, meaning that blood pressures and heart rates kind of wax and wane. The biggest risk, though, is something called malignant hyperthermia, which can be fatal. So I would just emphasize that these interactions are really quite rare, but certainly providers need to be aware of them. So I wanted to move on to talk about other antidepressants quickly here. Effexor, I think, is a very valuable medication, venlafaxine. It's unique in the sense that it increases not only serotonin, or 5-HT, but also norepinephrine. So these are called SNRIs, serotonin norepinephrine reuptake inhibitors, that I'm talking about. Now, in theory, if you increase serotonin and norepinephrine, maybe you're talking about a more effective antidepressant than one that just increases serotonin. But that's been kind of hard to prove. One thing that's kind of unique about Effexor is the fact that it increases serotonin at low doses, but you have to push the dose up to see this norepinephrine effect. So at low doses, really all it is an SSRI. It's at higher doses that it becomes unique when you start to see this norepinephrine effect. And in fact, whenever I see someone on low-dose Effexor for an extended period of time, my first question is, why aren't they on an SSRI? I mean, SSRIs are much cheaper. Their side effect burden is probably less than Effexor's is. So in terms of the side effects with Effexor, they're exactly the same as SSRIs: sexual dysfunction, nausea, withdrawal. And once you get up to these higher doses to see the norepinephrine effect, you're also going to see an increase in blood pressure quite often. So whenever we increase doses up to 150 milligrams a day or more, we routinely monitor blood pressure. So where Effexor may fit in is, I know psychiatrists have used it for years in patients who fail an SSRI. Their next step will be to try something like Effexor. So for severe or treatment-resistant depression, it's a good choice. Or for people who have neuropathic pain, like diabetic neuropathy or what have you. Duloxetine is very similar to Effexor. One minor difference is the fact that you don't see this dose-dependent effect on norepinephrine. Regardless of the dose, duloxetine or Cymbalta affects serotonin and norepinephrine. Side effects, very, very similar. There is some risk of hepatotoxicity with it. So if I'm seeing someone who has a very impressive drinking history, alcohol, I would hesitate to prescribe it in particular. But otherwise, I think it's also a very valuable medication. I think it's a little bit easier to use than Effexor, to be honest with you. It is an inhibitor of 2D6, as I mentioned. And this is the dosing, a lot more straightforward than with Effexor, and the same indications here. Now, Wellbutrin or Bupropion is really a workhorse, I think, in treating depression. It's used for a lot of different reasons. Very valuable medication. Completely different mechanism of action than the SSRIs. It has no effect on serotonin whatsoever. So it works by increasing either norepinephrine or dopamine. Norepinephrine is kind of similar to adrenaline, and dopamine is often called the pleasure neurotransmitter. So we may use something like Wellbutrin in someone who has really low energy, can't enjoy themselves. Maybe they're very listless, sleeping too much. The side effects, it's interesting. People either tolerate Wellbutrin really well or not at all. There's just some people who find that's a little bit too activating. They don't like it. They feel like they've drank too much coffee. Other people love it because of the boost in their energy. It actually may decrease appetite in some people as well. The contraindications, if someone has a history of seizure disorders, it's absolutely out. We can't prescribe it because it may lower seizure threshold. The dosing is a little complicated. I'm not going to get into that, but basically, if the provider follows the dosing recommendations, there is no enhanced risk of seizures. It's safe, as long as the person does not have a history of seizures. And you can see where it might be preferred. I mentioned low energy and anhedonia. Also, if patients come in and they tell me that they're interested and willing to try an antidepressant, but they don't want anything that's going to adversely affect their sexual function, Wellbutrin's often a good choice. I would say more often than not, when we're prescribing it in combination with SSRIs. So again, we'll start someone on an SSRI, they'll have a partial response, we may add Wellbutrin. Or maybe they're on an SSRI and they're having this problem sexually, again, we'll add Wellbutrin. That's called augmentation, the former. Mirtazapine or Remeron is used occasionally. It's really caught on in extended care facilities. The reason being that it stimulates appetite and it also is somewhat sedating, which may be a good thing under those circumstances in part of the population at least. It has a very unique mechanism of action. It was actually originally designed to be an antihistamine. So it's actually fairly sedating, but it does enhance serotonin and norepinephrine. In fact, as you increase the dose, it increases norepinephrine, so it becomes more activating at higher doses. Again, that's kind of paradoxical. Low doses, it's sedating. Higher doses, it becomes more activating. And it also has a really interesting property here. It blocks what we call the 5-HT3 receptors. This is a subtype of the serotonin receptors that's responsible for nausea. And so if you block these 5-HT3 receptors, you may actually be looking at an effective anti-nauseant. And it has been used for that purpose, for excessive nausea during pregnancy. It's also been used post-chemotherapy. I think I'll move on here. So I mentioned before that maybe half of the patients started on one of these antidepressants is going to need a change in their medication, and this is the way we approach it. We first make sure that they completed a full trial, that they continued to take the medication. We adjust the dose as necessary, but if they really don't have a response, what we're looking at is switching medications. And earlier I mentioned the STAR-D trials. I mentioned at least the first step of the STAR-D trials. People were tried on citalopram. One of the more interesting subsequent studies that they published was a switch study. So what they did is they took the patients who didn't do particularly well on citalopram and they randomized them to either Wellbutrin, again a totally different class of antidepressant, Zoloft, which is simply a different SSRI, or Effexor, which is again a different class of antidepressant. And lo and behold, there really wasn't any difference in response rates. So it didn't matter, I should say remission rates. It didn't matter what they switched them to. All the responses were about the same. In fact, there was a trend favoring Zoloft. Now, for us in practice in this field, this was really eye-opening. And the way I think most people have interpreted this study is that if someone fails one SSRI, the next step is probably a different SSRI, which implies that these drugs are different in ways that we don't really understand, the SSRIs as a class. Also, I guess that's kind of good news in the sense that most of them are generic. So we're switching among medications that are relatively inexpensive. Now, if someone has a partial response, we do something called augmentation, which is, again, adding a second medication. And if someone has a lot of low energy, sleeping too much, I'll add something like Bupropion. Whereas if someone's on an SSRI and they still have a lot of anxiety and irritability, I may add something like Buspirone. Brand name there is Buspar. It's an FDA-approved drug for generalized anxiety disorder. And then there's some other options here too, like adding lithium. If you look at it from an evidence-based standpoint, adding lithium to an antidepressant can actually be quite effective. And T3 is another option. This is thyroid supplement. Even if someone has normal thyroid functioning, if you add T3 to the antidepressant, it can be quite effective. And in fact, 5 out of 6 studies have shown very impressive results with T3. And another aspect of the STAR-D trial that I'm not going to get into actually compared lithium to T3 in combination with that citalopram, and they actually had very good results with T3, better than they did with lithium. So I think you're going to see people prescribing a little more T3 as an augmenting agent for depression. I know I am. So something I've alluded to a few times is that I basically prescribe antidepressants based on sort of the subtype of depression I'm looking at. And I think most of us in this field think there is something to targeting specific symptoms with a specific class of antidepressant. To explain, it looks like perhaps people who have a lot of anxiety and irritability do well on medications which enhance serotonin, whereas people who have a lot of low energy, can't concentrate, no motivation, can't enjoy themselves, do better on medications which enhance norepinephrine and dopamine, things like bupropion, amantadine, or even modafinil, which is Provigil, which you may have heard of. And then for the severe melancholic, maybe we want to do both, increase serotonin and norepinephrine. Now, I don't think the research has really caught up to this theory yet. I can tell you in practice, most people who use these drugs on a regular basis do think there's something to this, that we should be targeting specific constellations of symptoms and associating them with certain classes of antidepressants. And in fact, some of the pharmacogenomic research that's coming out is supporting this theory. But I do think that's one way we can improve outcomes is by looking at the specific types of depressive symptoms and matching it up to the classes. Owen Wolkowitz is a very accomplished psychiatrist next door at Langley Porter, and he basically boils it down to asking his patients, are you more worried than tired? In which case he goes with something that works on serotonin, or are you more tired than worried, in which case you go with something like Bupropion or Wellbutrin. You know, in talking about the mechanism of action of the SSRIs as being increasing serotonin in the synapse, you know, that actually happens within hours of the first time you administer it. And yet, why does it take a week or two before people start to feel better? We actually think it kind of resets this serotonin thermostat. There's a specific receptor subtype that if there's a lot of serotonin out in the synapse, it triggers that receptor to tell the presynaptic terminal to stop releasing serotonin. And we actually think the SSRIs, what they do is they desensitize that receptor so it doesn't get that message and you continue to flood the synapse with serotonin. Now, what that doesn't explain is why drugs which affect different neurotransmitters can have the same clinical effects. You know, that's the piece that we're missing. There's some really interesting evidence that what these medications are doing is actually increasing what we call neurotrophic factors in the brain. They've done some, it's really hard for me to know where to draw the line here in terms of explaining this, but they've done imaging studies looking at people with chronic depression. And what they found is that there's an actual shrinkage in certain structures in the brain. The hippocampus in particular has been very well described. It actually shrinks with chronic depression. When people respond to antidepressants, it grows. So there's a decrease in neurogenesis, then with response comes an increase, and they think it's due to an increase in these neurotrophic factors. So it could be that somewhere down the line, these antidepressants are affecting the neurotrophic factors. And I'll leave it at that. One more question. I have a lot of material, sorry. The one that there's probably the best evidence for, even if it's largely anecdotal, is Wellbutrin, being used as a third-line agent for ADHD. There is a lot of comorbidity between ADHD and depression, but you can't really make a blanket statement that the antidepressants are effective for ADHD, with the possible exception of Wellbutrin. That's not my area of expertise, child and adolescent psychiatry. So are there any other treatment options? I've already mentioned quite a few, but as you would imagine, very commonly people will acknowledge that they have depression, but they don't like the idea of going on an antidepressant, and or they don't like the idea of tracking down a therapist and going through psychotherapy. So they're looking for other options, and there are some other options. Does anyone know what this is? St. John's wort, yes. A flowering plant, obviously, that blossoms around St. John's feast day. St. John's wort, I do think, is worthwhile. There have been many studies now of St. John's wort. The problem has been that the methodology of these studies is all over the map. In Europe, in general, the results have been very positive, I think, to a large extent because they use a more powerful preparation. Whereas here in the US, it's been kind of mixed, but if you do something called a meta-analysis, which looks at the sum total of these studies, the conclusion appears to be that it's probably effective. So if I'm seeing someone who has all the symptoms of major depression, they're not willing to go on an antidepressant or pursue psychotherapy, I'll tell them exactly how to take St. John's wort. And the dose is 900 to 1,800 milligrams a day, and you have to give it a full therapeutic trial, which means a full month of it. It's relatively benign. In the European studies, they did find that it can be kind of anxiogenic. It can cause some anxiety. And we also know that it can cause photosensitivity. The way we know that is that sheep love to eat St. John's wort, and they eat so much St. John's wort that they get sunburned, literally. So it can cause some photosensitivity. Drug interactions are very important with St. John's wort. Unlike the SSRIs, which are enzyme inhibitors, St. John's wort is actually an enzyme inducer. So it actually revs up enzymes. It accelerates metabolism, so it can actually lower the concentrations of other drugs, which can be a problem like with birth control pills. If you lower the concentrations of the hormones, you could actually get an unwanted pregnancy. The worst case scenario with St. John's wort is with something called cyclosporin. Cyclosporin is used in people who recently had kidney transplants or liver transplants. They give it to them so they don't reject the new organ. Their body doesn't. And if you give them St. John's wort or they start to take it surreptitiously, what happens is you get this decline in their cyclosporin levels, and they've actually rejected these transplanted organs. The omega-3 fatty acids, I'm also very optimistic about. I think they're a great solution in certain populations like depression associated with pregnancy. And I think there's very compelling evidence that cultures whose diets are high in omega-3 fatty acids have much lower incidences of depression. In terms of what to use here, that's kind of the question. We don't know what the appropriate dose is. Yes, you can increase the amount of fish in your diet that actually contain a lot of omega-3 fatty acids, and I'm talking about salmon, mackerel, and herring, maybe lake trout or lake fish. Or you can do it through fish oil or flaxseed, but most people use a supplement. It's a little more efficient and probably less expensive. And in terms of the supplements generally contain two different omega-3 fatty acids, EPA and DHA. And again, we don't know what the ideal dose is. Best guess is it's somewhere between 1 to 2 grams, maybe even higher. And if you're really intrigued by this, Trader Joe's actually has, I think, a really good preparation, which has the appropriate combination of those two. And it's a lot less expensive than what you're going to find at Safeway or Whole Foods or what have you. And then there's also, I think, a lot of support for folic acid, something called SAMe, and even DHEA. And if you want to read more about this, in the journal Psychiatric Clinics of North America, there was a really good article last year. So 2007 Psychiatric Clinics of North America, which we carry across the street in the library. Now, for more severe forms of depression, there are other treatments. What this is alluding to here, this unfortunate picture, is something called ECT, electroconvulsive therapy, once called ultrashock. ECT is wonderfully effective. 80 to 90% response rates have been reported, very rapid response rates, often within the first week. The biggest problem it suffers from is a poor public image. So I'm probably not doing it any favors by showing that picture. This is how it's actually administered today. You know, if you mention ECT to people, what they inevitably think of is Jack Nicholson in One Flew Over the Cuckoo's Nest. But the reality of the situation is that the administration of it is relatively safe and uneventful. The reason being, first of all, that they don't give one giant continuous pulse the way they used to induce a seizure. They actually give a series of intermittent pulses, and they also give 3 different pre-treatments which prevent a lot of the complications. So they give atropine so people don't develop bradycardia. They give a short-acting barbiturate so they're unconscious for the procedure. And they give succinylcholine so they don't actually have the seizures. So you don't have to worry about fractures. In fact, if you've ever seen ECT administered, it's very uneventful. So it's very effective acutely. The big question is, how often should we administer it to maintain that response? It's been very difficult for people to get funding to conduct this kind of a study because it has such a poor public image. What's kind of interesting to note, actually, is that they've learned that there's a disproportionately high percentage of people who get ECT who are health professionals because they know it's relatively safe, they know it's relatively rapid acting. The side effects, there's been a lot made about the amnesia, retrograde amnesia, but actually the studies show that memory improves after ECT. You know, there are isolated cases of people who had some sustained amnesia, but it's fortunately quite rare. In terms of the indications, the major ones I would say are treatment-resistant depression and psychotic depression, which is someone who's depressed, but they also have psychotic symptoms. But the depression is paramount. Vagal nerve stimulation was FDA approved a year or 2 ago. This is a device which is implanted under the skin. It stimulates the vagal nerve, and it does appear to be fairly effective for depression and maybe even preventing migraine headaches. It's very expensive. I'm a little more optimistic about this, which is RTMS, reverse transcranial magnetic stimulation. This is not yet FDA approved, although there's now a handful of studies out there showing that it does appear to be effective for depression. Basically, it's doing the same thing that ECT was doing without inducing any kind of electricity into the equation. So they're inducing this magnetic field, kind of jump-starting the brain, if you will. Very benign procedure, and you can see not invasive at all. Now, I want to take a step back at this point and just kind of think about all the options I've already presented in terms of treating depression. You know, we really have to ask ourselves, why aren't the outcomes better for people who are depressed? And the answer is pretty complicated. I mean, you could talk about the fact that a lot of people don't like to seek treatment for their depression because of the stigma, or maybe they don't have access to quality health care. But I think a lot of us think that the problem here is really a systems problem. Again, that the mental health system is broken, that most patients with depression now are being detected and managed in primary care, which is not really designed to fulfill that function. So for instance, we know that over 70% of all people who are treated for depression are actually treated in primary care, and that 77% of all prescriptions are actually written by primary care providers. Unfortunately, most patients with depression still are not accurately diagnosed. I mean, ideally, everyone with depression, at least in my mind, would see a psychiatrist. But that's just not going to happen with today's healthcare system. So there's a lot of barriers to treatment within primary care. I mean, one of the reasons why the outcomes aren't that great, or several of the reasons here are listed. For instance, time limitations of the primary care providers. Studies have shown that actual face-to-face contact in a primary care clinic visit is somewhere between 7 and 11 minutes. I mean, if you think about it, that's almost incentive to not investigate the possibility of depression, because if you identify it, you really can't do it justice, with the remaining few minutes. The lack of familiarity with medications and comfort in managing mental illness, I do think that's improved in recent years. I don't mean to criticize primary care providers. I think there have been some strides made, but still, this is not the place to deal with depression, I don't think. And since many of these patients do need fine-tuning of their antidepressants, combinations of antidepressants or what have you, again, I don't think the system's designed for that. And lack of patient education and counseling. I can tell you in our clinic, I think one of the most important things we do is give patients realistic expectations of what the medication can do for them and when this might occur. I mentioned the fact that the government has intervened to some extent to try to improve the treatment of depression in this country. Something called the NCQA. This is like the governing body of the HMOs. And what they do is they target certain disease states to grade the HMOs based on how well they do. For instance, they looked at otitis media a few years ago to see how often antibiotics were prescribed in children for otitis media. They also looked at depression, and the three specific measures were what percent of the HMO's patients were adherent to the medication at 3 months, what percent were still on the medication at 6 months, and then they also looked at the number of contacts, with the recommendation being at least 3 contacts with the provider during the first 3 months after the diagnosis. So this is how they graded the HMO, and just to give you some idea how poorly we're doing in primary care, you can see a little over 40% of the people were still taking the antidepressant at 3 months. And recall that the minimum duration of antidepressant treatment is 6 months, minimum duration. And only about 40% were on it at 3 months. If you look at 6 months, well, it's about a third of the patients were still on it at 6 months, about 30%. And number of contacts, only about 20% actually had a sufficient number of contacts with their provider. So this is the 50th percentile, which is more or less the median here. And I'll just whiz through the 75th and 90th percentile. So we're not doing very well. I think this cartoon kind of hits home. You can rest assured, Mrs. Wilson, that your husband will receive the best care known to medical coverage. So what can we do? Well, there's been a number of historic interventions. There's been a lot of efforts to improve screening. For instance, screening people in waiting rooms in certain clinics where you're likely to find depressed patients, like OBGYN clinics, cardiology clinics, endocrine clinics. But the answer there seems to be that if you're going to enhance screening, you also have to have in place some kind of a system for dealing with these patients effectively. Improving patient education is definitely a big component, but again, I don't think that's the entire answer here. Mailing reminders is something that a lot of the insurance companies are doing, as well as employer groups. They're mailing reminders to patients or employees so they continue taking their medication. But again, I think that's just a piece of the puzzle. Telecare, what I mean by that is telephone follow-up. A lot of the protocols for improving the treatment of depression have involved telephone follow-up, but again, I don't think telephone follow-up itself is the answer. And the reason I say that is because there have been studies looking at the impact of strictly enhanced telephone follow-up, and what they found is, yeah, it's fairly effective. It's kind of a psychosocial intervention, but there's huge attrition rates among the healthcare providers making these phone calls because they don't have a relationship with the patient. They're just a voice over the phone, which is not very rewarding, talking to depressed people on the phone all day. So I don't think that's the entire answer. You have to have this alliance with the patient, I think, at least in the beginning, on a face-to-face basis. Web-based care is becoming more common. There's been some interesting studies published lately looking at web-based care for instance, bipolar disorder, for postpartum depression, where women may not be able to come into the clinic as frequently as they like, so they're conducting the follow-up over the web. But I think most experts think that it's collaborative care which is the answer here. And to explain what I mean by collaborative care basically integrates some kind of mental health specialist into the primary care setting. So they're integrated into the setting. It could be a psychologist, could be a psychiatrist, could be a psychiatric pharmacist or psychiatric nurse practitioner. And they become the case manager or care manager for the patient in primary care, but there's very close collaboration with the primary care provider. There's a lot of patient education and follow-up that goes on. Studies have shown that this is really quite effective. The question is, how cost-effective is it? How extensive should these interventions be? In recent years, there's also been more of an emphasis on using pharmacists to assume these kinds of roles as physician extenders, particularly in the area of depression and diabetes. The rationale here, I think, is pretty straightforward. Pharmacists are considered the most accessible health professional. As you would imagine, a lot of the time when people think they might be depressed, they go into the pharmacy first and learn about some of these herbals or supplements, or they go on the internet And in fact, the number one reason why people go on the internet related to health is actually depression. Pharmacists have a lot of training in the medical model. The doctor of pharmacy degree is now the entry-level degree, and the curriculum's designed to a great extent the way the medical school curriculum is. Other highlights here. Actually, pharmacists have been doing this, serving as physician extenders for almost 30 years in the VA healthcare system and Indian Health Service. And also, a lot of people don't realize that pharmacists can actually prescribe under protocol in over 33 states now in the country. That's what I do in my clinic. We have an institution-specific protocol which permits me to prescribe. And also, Medicare Part D now reimburses pharmacists for clinical care. So in terms of what they can do, it's all over the map. I have a number of websites listed here. NAMI and DBSA. NAMI is National Alliance for the Mentally Ill. DBSA is Depression Bipolar Support Alliance. These are both consumer websites. They're fairly good, I think. If you want a little more extensive information, UMass, the hospital, has a wonderful website for mental health as well as health in general, as does University of Michigan Depression Center, specific for mood disorders. And Langley Porter next door actually has a pretty good website too. So moving on down the list here, you can see there's a lot of areas where pharmacists could potentially intervene. I want to talk a little bit about care management, just because this is a little closer to home. Now, if you're wondering how physicians in the medical societies view pharmacists potentially as physician extenders, this was a quote from a position paper a few years ago in the Annals of Internal Medicine. Pharmacists continue to successfully expand their scope of practice. With the transition to the PharmD degree and automated dispensing, pharmacists are being trained to take a greater patient care role, and collaborative therapy is one of the best examples of how pharmacists work with physicians. So, several years ago now, we at UCSF collaborated with Kaiser Permanente of Northern California, specifically their medical center that's located in San Rafael. And we actually started a protocol where psychiatric pharmacists were actually managing depressed patients. So the primary care providers, when they thought someone was depressed, they referred them to us in this clinic. We assessed what we thought was going on. We got a complete history, a complete medical and psychiatric history, assessed target symptoms, identified stressors. There was exclusion criteria for which we referred them to psychiatry or mental health in general, things like imminent suicidality, bipolar disorder, et cetera. We then started the antidepressant, did very extensive follow-up. And I should also emphasize the role of the psychiatrist here. We have a psychiatrist supervisor who we would meet with every couple of weeks. This was the follow-up. You can see it's fairly extensive. And this, by the way, is the same protocol that I continue to follow now at UCSF Women's Health. We see people at baseline, a number of telephone contacts in between. You can see early on, the main reason we're contacting them is to make sure they're tolerating the medication, because responding to it's going to take a little while longer. And then they come back in about a month out, which is the duration of a therapeutic trial. And then we see them a little less often, and then we see them at 6 months to talk about whether or not we recommend stopping the medication, and if so, how to do that. Now, there's a lot of different functions we perform, I think, in this capacity, things like assessing stressors and target symptoms and starting antidepressants. But I actually think the biggest intervention here is patient education, giving people an idea what they can expect from the medication. So these are just some tidbits I think that everyone should know about depression and antidepressants in general. And I won't spend any time going over the specifics here. Now, we live in the ivory tower here. Most of us who are involved with this project work in academia. So the goal here was to conduct a study, a randomized controlled trial, looking at the effectiveness of this intervention. And so the way it worked is when the primary care providers thought someone might be depressed, just like they do every day, they refer them to our clinic, and then we randomize them to either being seen in our clinic, the collaborative care here, and the name of our clinic is the Medication Alliance Clinic, or they were bounced back to the primary care provider and they had quote-unquote usual care. Now, this is introducing kind of a subtle bias here if you think about it, because the primary care providers referred their patients to us, we randomized them, and if they come back to them, well, they know that they're in the control group. It's something called the Hawthorne effect in academic circles, which means if you know you're being observed, your behavior is going to change. they're going to want to do well. The primary care providers are going to want to have good outcomes with their patients when they're bounced back to them. The Hawthorne effect is called. So in spite of that, we actually had excellent outcomes. Our primary outcome was actually medication adherence. That is, how many patients continue to take the medication for the first 3 months and for a total of 6 months. This is the national benchmark for HMOs. You know, you can see it's a little bit higher for HMOs in this slide than it was for Medicaid patients. You can see about 54% of patients nationally complete 3 months. If you look at the control group, which was the primary care providers in our study, about 60% completed 3 months. And if you look at the patients in our clinic, 76%. And then if you look at 6 months, pretty much the same pattern here, 67%, which is almost unheard of. And we actually conducted 3 different studies, and the results were very consistent. So people were unquestionably staying on the medication longer. We also conducted a satisfaction survey, and these are some of the high points here. All these differences I'm showing you are statistically significant. In terms of the personal nature of care, over 80% of the patients in our clinic were very satisfied, considerably less with the control group. Although I would mention that the control group did very well compared to national averages. Again, maybe because of this Hawthorne effect. Availability of the providers, patients are very happy. Follow-up, they're very happy. And then a very interesting question we asked them, and these were anonymous surveys, was would you recommend a friend to Kaiser for the treatment of their depression? And you can see the vast majority of them said that they absolutely would, which made the administration very happy. And then we also looked at resource utilizations. And what you're looking at here is the number of primary care visits during the 12 months before they were referred to the clinic and then the 12 months after. And that's a highly significant decline. So there was at least a cost offset here as well. In the control group, it wasn't nearly as substantial. There was also a significant decrease in ER visits. So this protocol we've implemented far and wide. At one time, there was 10 sites in Northern California affiliated with Kaiser Permanente that had this protocol. I'm not sure how many continue to do so. This was a few years ago. You can see some of the other sites. One really interesting one is here in Asheville, North Carolina. They're actually doing a study very similar to our study where the employer is actually covering the cost of the medications if the patients are willing to participate in the study. So the employer is getting involved now, which is as it should be, I think, because they have so much to gain if the patients improve. And the preliminary results of this study actually have been very favorable, and they've gotten a lot of press. So finally, just a little quote here from Oscar Wilde. A cynic is a man who knows the price of everything and the value of nothing. And if you have any questions, I'd be happy to answer them at this point.